Welcome to the Pain Pod. This is the podcast where you can hear from your favorite physicians on their experience treating pain and how they got there. This week's episode, we are joined by interventional pain physician Dr. Kal Lingam, affectionately known to his colleagues and patients as Dr. Kal. Dr. Kal joined IPS Dublin in 2005, where he currently sees patients and serves as our medical director. Thank you for being here.
Thank you for having me.
Absolutely. So what brought you to pain?
So it was a interesting story. I've always been interested, obviously, in medicine and thought about that for a while. I did my anesthesiology residency and I enjoyed it, but I didn't necessarily like being on the surgeon's time. Everything that I do in the operating room was dependent on the surgeon. If they were having difficulty, we'd have to keep the patient sleep longer and things like that. So, plus unpredictable hours and things. But also, I didn't like that there was no continuity of care in anesthesia. You see the patient once before the surgery, you take care of them during the surgery,
Right.
and then you see them once afterwards, but you don't know their long-term outcome, which I didn't like. So that's when I started. I did a pain rotation, obviously, during residency and got the exposure, and I enjoyed it quite a bit. I still got to do procedures, which I love working with my hands, doing those types of therapies. You see results, and then there is also that continuity of care, and I can control my own schedule and things. So that seemed to be a very good fit for me.
Why is it that you see anesthesiologists go into pain specifically, right? Because you look at it and you see you've got PM&R and then you've got anesthesia. Where's the difference there?
I think it is definitely a spectrum, and depending on kind of the base residency training, the focus can be a little bit different, and because the treatment of pain is very broad.
Yeah.
It goes from purely interventional all the way to purely emotional, psychological type medication management based. So there's a lot of specialties within there that all have an important value in the treatment of pain. So I think anesthesiologists are the primary route because of the interventional focus of pain. In general, anesthesiologists being in the OR, we do a lot of procedures with our hands. We're intubating patients, then we're starting IV lines or arterial lines, things like that. So and then we're doing things, putting spinal blocks for labor or labor epidurals, things like that. So we have that kind of experience already. So I think in that respect, it's a natural transition. But the physical medicine rehab residents, they have excellent knowledge and awareness on the rehabilitation side of things, getting the patients better and back to their normal functioning and things, which obviously is very integral in the management of pain. So I think they have a very good role in that respect, and that's why a lot of them also go into pain management. So those are the two primary residencies that transition into pain management, but then you also have neurologists and things that go into it, and even some psychologists, psychiatrists that go into it as well. So, but yeah, anesthesia and PM&R, I think that's the primary reason. So, yeah.
So, good transition. Tell us what pain is to you. Like, what is pain?
Pain. Yeah, that's a very good question. So, in training, we're formally taught the International Association for the Study of Pain's definition, and that is pain is a sensory or an emotional response to actual or potential physical tissue damage. And that's kind of summarizing it. But so basically, there's a lot of stuff in there, but in my mind, I see pain kind of as a cycle where you have pain and you have mood changes, whether it be anxiety, depression, just any mood changes, and then those kind of feed off each other. So, you have pain, and eventually over time, it's invariable. You see mood disturbance, and then when you have mood disturbance over time, because of the pain, because of the mood changes, your mind can't shut down. You end up having sleep disturbance, and then that because you have sleep disturbance, that creates more pain, more anxiety, more mood disturbances. So they all feed off each other,
Just
in a
compounding
circular.
over time.
Exactly. Yeah.
Okay.
So in my mind, I see it as kind of all of those things, and every single person is unique in respect to the amount of each of those that they have.
Right.
And so that's why it's very important, at least when you initially see them, to kind of gather how much of each of those components is playing a role in their overall symptoms, because ultimately that is going to be the determining factor in how you treat them going forward.
Okay. So walk us through what a new patient appointment would be if a patient comes to see you, right? And determining what you've kind of just gone over.
Yeah, absolutely. So when we see a new patient, sometimes they're relatively, the onset of their pain symptoms is relatively recent. Sometimes it's several years or even decades after it started. So we have to assess initially, well, first of all, how things started. Sometimes there's no precipitating event. It just, they wake up with it. I've heard that quite a bit. Other times there's an actual event that triggered, whether a car accident, work injury, things like that. Other times, just normal aging. So we just find out kind of what the initial onset was, because that can help dictate. And then I find out what treatments they've had in the past. Well, before we get there, like what type of pain they have, where they have it, and the normal questions. And then what treatments they've had in the past, and how long ago that was, and things like that. So I ascertain all that. And then we also try to find out from a functional standpoint, what limits them? What are they not able to do that they would like to do?
Right.
Are they not able to walk further than 20 feet before they feel like they have to stop and sit down and take a break? Or can they not sit for longer than 10 minutes and they have to get up 5 times while they're watching a movie? Things like that.
Right.
Because again, and what I stress to my patients is, it's a matter of controlling the pain, but more importantly, it's trying to make them as functional as possible.
Get back to daily living.
Correct. Yeah. And that's because, again, that's the fact that they're not able to do the things they enjoy contributes to the mood component of this pain cycle that we were talking about. So that's our goal. And I tell the patient up front, look, I want to control your pain, but more important to me, I want to get you as functional as possible. So, and the pain scales, things like that we have are very subjective, as we know.
Right.
So even though the patient, in their mind, they feel like they're a level 7 pain, if they're doing what they want to do and they can, that makes them happier, then I'm okay with that.
Right.
I'd rather have someone be that than a pain level 2, but not still feeling like they can't do what they want.
Right. So it sounds like you like it if they come in, they have goals of where they want to get back to, or maybe where they would like to go. Do you see, I guess, like walk us through. So they come in, you assess, are we doing physical examinations? Is there anything additional to it? What do you like the patients to bring with them?
Yeah, absolutely. If we'd ideally like to have patients have any previous imaging they've had brought to us, whether it be x-rays, MRIs, maybe they saw a physical medicine doctor, a neurologist, they have EMGs or something like that, nerve conduction studies. Any of that type of information is very helpful. And I preface that, and I tell this to patients too, they have imaging, and that's great because it can help guide us.
Yes.
But I tell the patient all the time that I treat a human being. I don't treat a picture.
Right.
And any imaging only shows what it looks like at that one moment in time. And there is a high variability in imaging based on the way they take the images and things like that. So things can actually not be there when they actually, or not show up on the imaging when something is actually going on. So that's why, to your point, a physical examination is extremely important. That's how we primarily determine what our treatment plan is. And again, if the imaging study correlates with what we see on the patient findings, then that's fantastic. But we primarily use the examination. So we get a detailed history of these things that we talked about, what they've had in the past, where their pain is, how it's impacting them. I like to educate my patients a lot. So that's where I try to spend most of the time with them. discussing options. And I always say this, look, we're a team, we're working together. It's not me telling you what you have to do.
Right.
There are some things that are, that are very, very important that I stress more, but I say from a treatment standpoint, we can do all of these things, okay? And we can start with one thing versus another if you prefer, because there's other factors that we have to consider. If there's transportation issues, maybe we do kind of independent things first that they can try on their own before they're coming back to us frequently, for example. But give them the option and then kind of talk it out and see what works best. But my philosophy is to always do the simple things first. If there's several treatments that could be an option, we always start with the simple ones and then kind of progress from there, because the challenge with pain, and I say this too to all my patients, is that, for example, low back pain, there could be several structures contributing to the low back pain.
Right.
We do the exam, and yes, that directs us a little bit, but it still doesn't give the full picture of exactly how much pain is coming from a particular source.
Right.
So I always tell them when we do treatments, especially interventional treatments and things, that one way or the other, meaning if they get relief or they don't get relief, we get information. We are learning information. If we target a specific structure within the spine as a source of pain and they don't get significant relief, well, I know it's frustrating for the patient, but that still gives us information that, hey, we got to look at something else for that treatment or for the management of those symptoms. And the patients understand that. I think if you set those types of expectations up front, saying, this is the process we're going to go through. It may not be a smooth road all the way through and get you to your goal right away, but this is what you can potentially expect. So I think that allays some of their concerns and fears, and again, sets the expectations.
That's great. It's definitely a journey, and it's no journey is a straight path.
Right.
So walk me through a couple of different interventional procedures. I know you mentioned that's something that, a little longer down the line you can get into with patients. What are a couple that you find work really well? What do they treat?
Yeah, absolutely. So there's a couple ones that I like in particular. One is, I guess from least invasive, if you want to call it that, is radio frequency ablation.
Okay.
And basically that is the application of heat to a sensory nerve that's causing pain. Okay. Typically it's done for chronic low back or neck pain, spinal pain. Yeah. But in theory, you can do an ablation procedure on any sensory nerve in the body to affect pain. Right. So I oftentimes, in addition to the spine, I do it for the shoulder, for the knee, or probably the next two most common areas. I've done it for rib pain. I've done it for pain after patients have had hernia repairs and they still have ongoing inguinal pain. So it's pretty effective in all of these cases. So basically it's still an injection, which is nice, minimally invasive, no downtime or anything like that. We do it right here in the procedure room. So for example, in the spine, the patient is laying on their stomach and we numb up their skin, and using the x-ray, we know exactly where we are. And then we go down with the cannula or the needle, get down to the location where that sensory nerve is, and then we put the radiofrequency probe through it. And basically what it does is it delivers a small electric current through that probe to the tissues, and then it creates thermal energy. Basically, you're converting electric energy to thermal energy, and by thermal energy I mean heat, basically. So basically you get the ions, that electric current causes the ions in the tissue to start moving, which creates friction. And that friction is what creates the heat. So it's not the actual tip or
it's not
the
physically
probe
heating up.
Yeah, the probe itself, but the tip is because of the local tissue movement. And then what it does is it kind of strips off the outer covering of the nerve and kind of deadens the axons of the along the nerve path, so they get that long-term potential pain relief. We're looking 6 months to 12 months ideally of pain relief. And eventually those do grow back and the pain returns. And the nice thing is there's been a lot of studies shown that you can repeat this over and over again without necessarily significant detrimental damage or anything like that. You know, so it's a very nice tool to have in our toolbox to provide patients for long-term relief. So. So that's one of the things that I really enjoy doing, because you see the results relatively quickly and patients do very well from it. So another procedure that I like, or I guess condition that I like to treat, is spinal stenosis, lumbar spinal stenosis. So it's a very common condition that historically has not had very good treatment options.
And this, for people, I always like to point out, is like the shopping cart, right?
Yes, the shopping cart sign, exactly.
Yes.
So people with spinal stenosis just means narrowing of the spinal canal.
Right.
And there's not necessarily direct compression on the nerves going down into the legs or anything like that, but when they're up on their feet, that narrowing of the spinal canal puts increased pressure on the spinal cord and the nerves exiting. So the longer they're on their feet, whether it be standing or walking, they start to develop pain, increased pain in the back, extending maybe down into the buttocks or even going down into the legs, to the point where they have to stop and sit down, whether it be for 30 seconds or a minute or two, before they can get up, and then they go for that distance again. That pressure builds up so badly they have to sit back down. It's that kind of constant up and down is typically what we see. And what you had mentioned earlier, the shopping cart sign, is kind of the classic thing. And that is a question that we ask in the grocery store. Do you go and you lean on the shopping cart to get around? And they say yes, all the time. So we look for those. And basically by leaning forward on the shopping cart, you are opening up the spinal canal, alleviating some of that pressure. And so patients do that to be able to go for further distances and things. So there's a couple different techniques that we can use, and there's been treatments, you know, off and on for the management of this, but two of the good ones that we have currently are called the mild procedure, which is minimally invasive ligamentum decompression, and the Vertiflex procedure. So they treat the same thing, but they're done by different ways. The mild procedure, basically it's indicated specifically only for thickened ligament that's in the spinal canal, which occurs over time with degeneration of the spine. The ligament actually gets thicker, and you would think instead it would get thinner, but it actually gets thicker, invades into the spinal canal. So we make a small incision on their skin, again, laying on their stomach, using x-rays, things like that. We make a small incision on their skin, and then take some instruments to clean out that thickened ligament from the backside of the spinal canal. So we actually never go into the spinal canal. So it's very safe in that respect. And that's why we as interventional pain physicians can do it. It's an outpatient procedure. Depending on if there's multiple levels or just a single level, procedure takes probably about 45 minutes to an hour or so, but they're home later that day, and no real restrictions in activities or anything like that. Certainly we don't want them to overdo it, but you know, it worked very well for patients. And then the Vertiflex procedure is similar to treating the spinal stenosis, but this is actually an implanted device that also, we make an incision on their skin and their back, and we put this between two of what's called the spinous process. When you run your finger down the center of your spine, the little bony ridges that you feel, those are called the spinous process. And you basically put in this device between, it's a spacer device, so you put it in between the two levels that are affected, and you kind of open it up or deploy it. And what that does is that it kind of opens up that space a little bit. And we're talking millimeters here, but that is enough to open up that spinal canal again, to alleviate the pressure from the stenosis. So those work also extremely well, and those we use in cases that are where the spinal stenosis is related to other causes. For example, there can be several causes of stenosis. It could be due to joint overgrowth within the spinal canal. It can be due to disc herniation. It can be due to that ligament. So there's a lot of different causes, but if it's other causes contributing to the stenosis, then the Vertiflex procedure works very well for that.
And what's great is they're both minimally invasive, right?
Exactly.
So our downtime's minimal.
Exactly.
We're able to get back to our daily activities maybe a little bit quicker than a very intensive surgery.
Exactly. Yeah. And that's the really great things about these companies coming up with these new treatments that we can do in a minimally invasive fashion, where historically it would be, to your point, big open surgeries and a lot of downtime, recovery time. Obviously, the larger the incisions and longer recovery time increases the risk for complication, infection, things like that. So it's nice that we have these types of things available to our patients now, and the outcomes are really fantastic. The other thing that I like as well, that I like to use a lot, is spinal cord stimulation. And that is a modality as well where ultimately, it's an implanted device where you put these electrode or wires, leads, whatever you'd like to call them, in the spinal canal in the epidural space, the same space where pregnant women get their labor epidurals. And basically, each of these wires have contacts that you can turn into an anode or a cathode and basically drive energy between them. And you typically, depending on the situation, you typically put 2 of these wires in so they can talk to each other as well. But what it does is it stimulates the spinal cord that's directly in front of it, and it scrambles the pain signal before that signal goes up to the brain through the spinal cord to be processed as pain. So basically it masks the pain. From a structural standpoint, we're not changing anything. We're not doing anything like that, but it controls the pain. It allows the patient to be more functional, again, resume their normal activity, things like that. And there's been a significant evolution of the technology since even the past 5-10 years. There are several companies out there, and each have kind of some unique features and things, but it's great because it's not requiring any medications, and the patient is in full control of this system at all times. They get a handheld controller. You can put multiple programs on the system. So if the patient has, again, I'm just using the low back, but if they have back pain and leg pain, you can put on a program that will just cover their back pain, or you can put on one that covers their back and their right leg, or back and left leg, or just their leg pain. And the patient has full control to be able to change this as the need arises. And you can use it 24 hours a day, including at nighttime. So patients also can see improved sleep, which again will help kind of break that cycle a little bit, help control the pain, which then helps the mood. And so that's kind of restored to a certain extent. And the other nice thing about the spinal cord stimulation is that it's fully adaptable. So if the pain were to change, the representative from the company can come and make adjustments on the system itself to account for any changes in pain location, pain intensity, pain type, things like that. So it's been a really fantastic option for patients as well. And I said ultimately it's an implanted device because the nice thing about this is that before there's any cutting on the skin, before it's put on or anything's put inside, we do a trial first for 7 days. Typically 7 days. It can be 5 days or whatever, but typically 5 to 7 days. We do that right here in the office. And so we place these leads, which are then sticking out of the back. Everything is secured and self-contained, and it's connected to an external battery pack that they wear for the week. And they test it out as if it were the real thing. And at the end of the week, we just bring them back into the office, gently take those leads out, and then we kind of see what their response is. What I personally do is I look for 5 parameters when we do a stimulator trial. Number 1 is if they had a reduction in their pain. Obviously, that's one of the main reasons.
Is there a certain percentage you look for, or is it just you know, like, I mean, 10%, like someone comes back like, oh, it was only 10%.
Right.
Or then you have someone else will do too, right? Like 10%, if someone else comes in, it's like, you know, I think I had like a 60%. Like,
Right.
what does that look like?
I would say at bare minimum, 50%.
Okay.
Not only for us, but also for the insurance company and things like that too,
Right.
which I completely understand.
Right.
Anything less than that, they're on the fence.
Okay.
I personally look more for like 70 to 80%
Okay.
relief.
Yeah.
And I'm pretty selective in who I choose for this modality anyway, but I look for a 70 to 80%
Okay.
improvement.
In the trial.
In the trial, yeah. And again, that's also very subjective.
Right.
So reduction in pain. And if they're able to cut back on some of their pain medication, if they happen to be taking them. And when I say pain medication, that could be anything. Anti-inflammatories, it could be muscle relaxants, it could be like gabapentin or...
not just an opioid,
exactly.
Any sort of medication that helps get them into their daily activities.
Correct, Tylenol, things like that, whatever they need. So do they have less pain? Are they able to cut back on their pain medication? But are they able to do more than they were able to? So cutting back on these and having less pain, but still being able to do more, that's very significant. That goes back to that functional ability that we were talking about. And then are they able to sleep better?
Yes.
You know, again, less tossing and turning or not waking up as many times during the night, whatever it is, or difficulty falling asleep. All of that a little easier. And then the fifth thing is how they feel overall, their mood. Are they happier and they have a more positive outlook on life? And sometimes it's the patient's family and the people around them that notice these things a little bit more than they do. So that's why it's important that when we do the trial that we have someone that's going to be kind of with them for a little bit and that can also observe them, be the objective measure of that last component. So when they come back in, we ask them all these questions because all of these are extremely important. And if we can achieve kind of our standard in each of these, then we say the patient is a good candidate to move forward. And so getting back to your point about the percentage of relief, it is the percentage of relief, but then I also do incorporate from the functional standpoint, if they say that, yes, I was able to do so much more, it's 50% relief. I mean, that's good. Again, that's my bare minimum. But man, I was able to go through the whole grocery store without stopping. I was able to sit for longer. That is much more important to me. So when you add that on to the additional 50% benefit, then I think
it makes it more appropriate.
Right.
Okay.
Yeah. So
that makes sense.
Yeah. So, and the nice thing is, too, going forward, the technology's constantly improving. You know, the batteries. So this is essentially a pacemaker, but instead of going to the heart, it's going to the spinal cord. That's where we're stimulating. So, you know, the batteries right now, depending on the company and things like that, are about the size of an Oreo in all dimensions, maybe a little bit bigger. So it's not terribly invasive being inside the body, but as technology improves, the batteries are getting smaller and smaller. And the batteries are there's rechargeable and non-rechargeable, and they have a finite life, both rechargeable and non-rechargeable. But as the technology improves, that lifespan is increasing significantly. So you don't have to go back in to replace them as often. And we're talking into 10 plus years. That's already out now, but even as they get smaller and smaller, the technology inside of it still will enable us to maintain that 10 plus year replacement interval, which is great for the patient.
Right.
So the other nice thing about stimulation, we talked about spinal cord stimulation, but there is also, and again, we gave the example of the low back, but you can also use this for the neck, patients that have had previous cervical surgery that continue to have nerve irritation, low back irritation, whatever it might be, with symptoms going to the shoulders, arms. This is a great modality as well. But in addition, there's been a significant improvement in what's called peripheral nerve stimulation, where, kind of going back to the radio frequency ablation, where you can do any sensory nerve in the body. You can technically do this for stimulation for peripheral nerves as well. So people that have chronic shoulder pain as well, or even knee pain, you can stimulate the sensory nerves, the same ones that we target for the ablation, but you can place a small thin lead there, and that can also provide substantial 24 hours a day long-term relief as well. So it's nice to be able to have that option again for patients that historically have not had that available to them. And this is including in patients that have had shoulder replacements and knee replacements and things. You can still place this. And unfortunately, you would think that after having a replacement, you wouldn't have any pain, but you can still,
have pain. Your
still have
nerves
pain.
are still there.
Exactly.
Yeah.
And I see a lot of those patients that have the residual pain even after having extensive surgeries or replacements, and these modalities work fantastic for them.
With these modalities, though, do you ever have patients who come in with concern of like, it's going to still prevent me from having maybe like a full range of motion again? Obviously, if they're physically able to have a full range of motion, I know sometimes after some procedures it does, maybe outside of what we're talking about. But, sometimes if you've had something removed from your body, it can impede your range of motion. But I guess more specifically, like with the implantable devices, are we still able to, like, say my goal is like, I want to get into the gym, right? Like I used to do that. I can't do that because I'm in so much pain. I really want to get back into the gym. I might not be doing powerlifting, right? But I would like to have that sense of physical activity again. Does that in any way impede their ability to do that?
It depends on, to your point, like it depends on the degree that they want to get back into it. I always tell them, so we can place the leads and place batteries and things like that. They have external batteries as well that they can disconnect and things that communicate through the skin. So if one example would be, if they're going to the gym, they just not have the system on per se, but they can turn it on right away after they get out. But using your gym example, I always tell patients just do slow, controlled movements at the gym or just even in life. Meaning, in general, they know kind of what their restrictions are. Yes, we want you to be able to do more and things like that, but don't overdo it and don't reach way overhead into the cabinet, and don't make sudden movements that you know is going to aggravate it. Sometimes people forget about that because their pain is less and they feel like they're back to normal. Well, if they still have to exercise caution in that respect. And then I do have a very a long conversation with patients that do want to get back to exercise and things. I tell them to minimize any sort of high impact type of activities that causes a lot of force to go through the body and puts more strain on the already irritated structures. But especially as it comes to, for example, weightlifting, just slow, controlled movements, and make sure you stay within the proper weight ranges that you know that you can handle. As long as the patients are aware and are conscientious of how they are carrying themselves and what they're doing. I want them to do what they want, but they just have to be aware. A lot of times too, just in terms of pain treatments, not just stimulation, but just anything that we do, it's a process. And this is just the jump start to allow them to be more functional. So it's not uncommon. We do treatments and then we get them back into physical therapy or aquatherapy, whatever level they're at, we kind of adjust accordingly, because again, this is the first step, and then this will enable them to have a better response and do more in these kind of aftercare therapies and stuff. And we're very, very lucky that we have Katie Wiley here, our physical therapist. She's excellent, and she really tailors the program for the reconditioning properly, so the patients make good, steady progress. So we're very lucky to have her. And I tell patients that too, this is a stepping stone, this is a start, but they also have to be engaged and motivated to take the steps they need to do, whether it be lifestyle changes or, again, exercise changes. They have to change their diet, whatever it might be for that particular individual, to get that long-term benefit and positive outcome.
Get back to maybe a new way of life, right?
Exactly.
Well, we do have resources online as well where people can look up the different procedures we've talked about. We also have a bunch of different videos, blog posts. We send out our newsletter, but we have a lot of resources for our patients, and I know that's important to you. If your care philosophy is an empowered patient is a patient who's going to get better.
Yeah, absolutely.
Have an active role in your life.
Yes, absolutely. Yeah, we're here to facilitate and give guidance, but ultimately it's up to the individual to be their own advocate and do whatever they can to get better.
Awesome. Well, I appreciate you taking the time to chat with me
thank you.
Kind of go over some procedures and what options are out there for patients. Again, if anybody wants to learn more, we've got OhioPainSolutions.com. We have a bunch of information in the office as well. Current patients, if you're curious to know more, give us a call, schedule another appointment. Do you have any last words for us?
No, just this is it's an honor to be able to take care of people and help them, and it's been an interesting ride, and we have such a great organization. I couldn't be happier being a part of such a great collaborative group here in Ohio as well as Indiana. All the physicians have been absolutely amazing, and I would trust any of them to take care of a family member. So if you're out there looking, think of us. You're in great hands, whoever you end up with.